thank you for the wonderful introduction, Christina. And I have to say, it's such an honor to be here to present in this absolutely exquisite facility you have and to see people in 3 dimensions. What an incredible treat. When I do a talk like this, I like to think about the population that we're serving to kind of ground us about why it is we do what we do. So I brought this morning a poem that one of my patients wrote for me about her experiences with depression in pregnancy. You say that I'm depressed. I wonder if you understand. You've never lived, I think, in this God-forsaken land. I always fight to function. I'm fighting to survive. I'm desperately trying to remember what it's like to feel alive. You say I'm carrying life inside. How can it really be? How can life possibly survive in a non-existent me? I like this poem because when I started my career now 3 decades ago, the mandate was the woman's taking a medication. She must stop all medications because she's pregnant. And what drove me to this career was believing and thinking and being committed to the fact that a healthy mom is critical for a healthy pregnancy. So my talk is on mitigating melancholy in motherhood. I have no conflicts of interest, and I'm from the Asher Center for the Study and Treatment of Depressive Disorders at Northwestern University. And you can see the team that I have, a wonderful team that is really responsible for a lot of the data that I'm going to present today. So what I want to cover today is a clinical review of the identification of perinatal mood and anxiety disorders and pharmacotherapy of those disorders. So I'll cover the disorders and offspring and maternal outcomes, epidemiology, pharmacologic agents for these disorders, and then the domains that we think about for looking at outcomes related to exposures to either the disorder or the drug. That is malformations, preterm birth, neonatal signs, and child development. I'll also talk about a real challenge we have, which is managing dosages across pregnancy and postpartum, given that pregnancy is such a dynamic physiologic state. And finally, I'll finish with comments on where are we? What does this literature tell us about treatment of these individuals with mood disorders in pregnancy? Our colleagues in OBGYN have really been attending to perinatal mood and anxiety disorders because they are seeing it as they see and treat women across pregnancy and postpartum. In psychiatry, we're a little bit behind in terms of paying attention. That's because we are the obstetricians, we are people who can say, gee, you're pregnant, I can't treat you, go to somebody else. But the OBs, again, have been really helpful in advancing the study of these diseases in pregnancy. They also recognize that these illnesses are associated with increased maternal and infant mortality and morbidity. And there's a wonderful article in Obstetrics and Gynecology that shares with obstetrical practitioners how to screen, how to treat these disorders within obstetrical practice. And every illness that we think about in obstetrics, every type of negative outcome is associated with these disorders in pregnancy. We also worry about early social and emotional development. So for example, if this mom is incredibly overwhelmed by her illness, unable to respond to her infant, social and emotional development is impacted. So for example, our duty as caregivers when an infant is uncomfortable, crying, fussing, is to help that baby move to either a comfortable, awake, alert state or sleeping. That's what caregivers do. And if she is unable to do that, the infant, the newborn, gets an entirely different view of the world early on than if the infant has a real responsive caregiver. The other important point that has mobilized our field is that In America, we have a rate of maternal mortality that's twice that of other developed countries. So you see in this graphic, the total deaths by 2018, 2019, 2020. And here in non-Hispanic Black women, we have an incredibly high rate of maternal mortality. And so our field is mobilized to say, what can we do as mental health professionals to reduce this unfortunate and frankly devastating and deplorable risk here in America? When we look at what are the causes or what contributes to these maternal mortality statistics, our mental health conditions are about 7% of preventable deaths, similar to preeclampsia and eclampsia. And I just finished working with our obstetricians at Northwestern and 2 other sites on a preventive strategy, a multi-million-dollar grant to prevent preeclampsia with a statin drug that's in large-scale clinical trials now. Where are the large-scale studies of preventing the illnesses that we treat? So what is the scope of this difficulty? What is the scope of perinatal difficulties, perinatal mood disorders? It's huge. And present information from a population study I did years ago now, but it's unique because it's an obstetrical population. It's not a psychiatric population. 10,000 women that gave birth at the maternity hospital in Pittsburgh were screened at 4 to 6 weeks postpartum. And 14% of those women has a positive screen. That's pretty typical, 14 to 15% on the Edinburgh postnatal depression scale, which is a commonly used measure. When the women screened positive, we offered them a home visit. We did an entire assessment with the SCID, diagnostics, referring them for treatment, following up. And we asked them, when did this illness that you were screened for at 4 to 6 weeks, when did that begin? Interestingly, there were several sets of patients. About a third said this illness began when I was pregnant. Often they would say it got worse after birth, but it began when they were pregnant. That's 9 months, right, across pregnancy. In that 4 to 6 weeks postpartum, 40% of women said it began then. And that is, again, typical for this postpartum stressful, massive endocrine withdrawal period that we know is a high risk period for the onset of these disorders. And finally, there were a group of chronically ill women, a quarter of whom were ill long-term. So now in Illinois, we do screen for each trimester for depression as well as postpartum. And in Illinois, screening is legally mandated. That's not consistent across states, but because of these high-risk times that where we have a chance to identify individuals who are pregnant, screening is important. That said, you all are probably experiencing what we are in that right now, our wait list for our department for an appointment is 6 months. In our center, we preferentially take pregnant and postpartum women and are incredibly busy because we can't stand to see these ill women untreated out there. But it's a real problem and we really need to expand our services. When we did our diagnostic evaluations, what we found was that the most common diagnosis identified in that 4 to 6 week postpartum period in this huge population was recurrent depression with a comorbid anxiety disorder. So the idea that we're seeing single episodes, new onset, really was not the case. These are women who told us, oh yeah, I've had anxiety disorder, GAD, PTSD, panic, long-term, and then I started having depressive episodes. The opportunity to intervene earlier in the life cycle. I mean, the child psychiatry, which I have calling to me saying, why are we letting these women continue to give birth and have these recurrent episodes? What can we do for prevention? The other issue is that, again, in these women who screened positive at 4 to 6 weeks postpartum, diagnostically, over 20% of these women had bipolar disorder, usually undiagnosed. And we know that the postpartum period is one of high risk for either recurrence or new onset hypomania, mania, although the majority of episodes in these women are depressed episodes. But still, here we have this incredible group of women who are really in need of intervention. So one of the problems that we tackled was that the vast majority of these women are being identified in obstetrical or primary care practices, not psychiatric practices. And so the screening that we're asking them to do in Illinois is getting done. But what happens in those practices typically is it's a positive screen. Oh yeah, you've got depression. Here's a prescription for an antidepressant, because that's what's available in primary care practices. So what we are concerned about and what we were seeing were a portion of those women developing agitation, activation, or overt hypomanic episodes. So we began to think about how do we help these practitioners identify those women at risk for bipolar disorder. So we added the mood disorder questionnaire to our assessment battery, and we knew which of these women had bipolar disorder. So we asked the question, if when we couple the MDQ with the EPDS, can we identify those women who had bipolar disorder diagnostically? What we found was when we used the traditional scoring, and I'll show the measure in a minute, about 50% of women were identified as having bipolar disorder. When we omitted one of the criteria on the measure, we got 70%. And so here's the measure. What we now do is we completely omit this, where you see the X's here. We omit that because we find that patients don't seem to identify the level of impairment. When they describe the impairment to you, it's severe, but they don't see it as a big problem typically. When we omit that, we picked up 70% of the folks of these individuals who had bipolar disorder. It's still not 100%. But as you know, bipolar disorder is sometimes difficult for psychiatrists to make the diagnosis. So at least this is a tool. And our practitioners now, most of them do the EPDS, but before they prescribe, they also do an MDQ. So it's a way to get some control over that difficult situation. So what about treatment? Well, antidepressant use is pretty common in pregnancy now. When I first started in this field, I was criticized severely for giving tricyclics back then to pregnant women. It was the post-thalidomide era of, oh, you got to stop all meds. You have to protect the fetus at all costs. Over time, there has been much more of a sense of healthy mom, healthy baby. And so now antidepressant use is about 5% of pregnancies in America, sort of variable across states, but still fairly common, in part because of this change to looking at the health of the mother. So how do we then interpret the studies that are out there? It's been fascinating to look at the early studies about meds in pregnancy. And you all remember that the pharmacist not giving women prescriptions in the third trimester because of neonatal signs. You know, we had situations where pharmacists were refusing to prescribe or to fill prescriptions for medications. And that is largely because of confounding. And it is still, I think, the bane of interpretation of observational studies. But luckily, the epidemiologists and statisticians have created better ways to look at these variables because we can't randomize pregnant people to treatment. So the problem that we've had is if we use a drug and we look at some outcome like birth defects, the drug is always used for a disease, and the disease is accompanied by all kinds of variables that are also affecting the rate of the outcomes. So one of the key papers in this area that really showed this point was Krista Heibrooks, who's an epidemiologist at Brigham and Women's, and her study in the New England Journal of cardiac defects associated with SSRIs was really telling. And what she did was she said, all right, I'm going to look at cardiac defects related to antidepressant exposure first trimester. And then I'm going to look at those women who took SSRIs and those women who didn't take SSRIs. And if you do that, which is like all the earlier studies, you find an elevated risk of whatever outcome it is in the medicated group. But then she said, I'm going to limit it to just people with major depression. So only diagnostically major depression and SSRI, major depression, no SSRI. And so this became insignificant with a confidence interval that included 1. But then she said, I'm going to do high-level propensity score matching, a way to adjust for things. In a simple way of thinking about it is, so a woman who's obese who takes an SSRI and who has major depression, or a woman who's obese doesn't take an SSRI and major depression, the strata of these variables are created completely then non-significant. Most of those variables then, the variable that is shown not to be associated or associated with such a low level that you can't really define it is the SSRI in pregnancy. And this is just another way to look at that. So with an odds ratio of 1, that means the exposure is the same as non-exposure. You can see if you just look at unadjusted analysis, they're all significant. Major depression only, they're moving towards 1. And then with the look at the confounders, the association disappears. This is a critical paper in our field because it really aligns us with, okay, what are we really looking at when we're treating these patients? So another question is about preterm birth. So we published a paper a while ago and looked at, well, what is the rate of preterm birth in a population with no exposure at all, this first column, or medication throughout, no breaks, or no medication but depression. And as you can see, the rate of preterm birth is over 20% in both of those exposure groups. I was disappointed because I wanted to find that the medication throughout group had less preterm birth, but that is not what we found. And I have, of course, some ideas about why that might be. So Helen is a Scandinavian investigator who published this study, and it is also a remarkable study because the literature is full of, you people prescribe these meds and these bad things happen. None of us would prescribe a drug if we didn't think that the benefit was for the mother-fetal pair was outweighed the risk. Where's the data to show that the outcomes are better? It's not there. But these types of papers are beginning to emerge where what she found when she compared women who took an SSRI versus those who didn't in pregnancy in a large Scandinavian sample was a lower risk for preterm birth. And this is significant. It's like a 26% reduction in the risk for late preterm birth, a 48% reduction early, and a 30% reduction in cesarean sections. Now, this has not been replicated. They're amazing data. And the hypothesis is that, well, perhaps in Scandinavia, they're better at treating. They're more aggressive with their dosing. They're they use plasma levels more than we do. I mean, is that it? Plus, the Scandinavian health system certainly offers advantages beyond ours. So is that what's going on? They didn't collect any symptom data though, so we don't know. But it's really interesting. They did find, however, neonatal signs, and they found lower APGAR scores and a higher need for NICU admission. So certainly there were effects of these medications in pregnancy. So what about neonatal signs? This field is really a mess. So we worked with the FDA a while ago to say, well, what are the signs that people are reporting to the FDA in antidepressant exposed infants? And you can see it's this mix of CNS signs, neuromuscular signs, GI signs, irritability, restlessness, rigidity. Kids unexposed get this stuff too. It's just at a higher rate in moms who are exposed, or babies who are exposed. But what's really a problem here is every paper you read has a different definition, a different outcome measure. There is no consensus definition about what it is or the course that it follows. So what is it? Well, is it some sort of side effect from serotonergic stimulation? Is it withdrawal? The vast majority of people call it withdrawal. I think it's very unlikely to be withdrawal, except the other thing that we do is ignore the pharmacology of these drugs. So from paroxetine, it could be withdrawal. You could get cholinergic overdrive from that drug, but to say a baby exposed to fluoxetine is in withdrawal is really nonsensical, since that drug has a long half-life, it's metabolized, and the babies have trouble getting rid of it. So we really don't understand what's happening. And finally, are there biochemical or structural brain changes, a neurobehavioral kind of effect that is acting? We are just analyzing data from a study now that we did, where we did serial ultrasounds for half an hour of neonatal behavior, fetal behavior. And then we did 24-hour videotaping of the babies when they were born with Amy Salisbury, a colleague at VCU. And what we are trying to look at is, do these things that we're calling neonatal signs, do they just occur at birth, or are we saying that are we observing these things prior to birth to get a better sense of the mechanism? Let me go back. What I have been concerned about is, what I have been concerned about is respiratory function. So you all know, for a while there was a neonatal persistent pulmonary hypertension in a newborn, and a lot of angst about that, until again Krista Heiberg's group published a large-scale study with appropriate and detailed propensity score matching, and showed that it was really not a significant relationship and extremely rare, 0.3%. So very, very, very rare. But we were working with a neonatal fellow, and we saw in our hospital that kids exposed to SSRI seem to require neonatal respiratory support in the delivery room. So she actually did a study, and it was the case that the kids seemed to have more difficulty in the transition to respiratory function outside, when they were born. And so 12% of the kids who were SSRI exposed needed a little positive pressure, a little oxygen stimulation of some type. And they did also have twice the rate of going to the NICU. However, the important thing we observed was this was really transient. By the time they got to the NICU, some of the NICU docs said, "Why is this baby here?" And all of the kids, the hospital stay was the same. There was no difference in the length of stay between moms and babies. But what is that? One of the hypotheses is that we looked at, in our ultrasounds, it looks like the fetal breathing, practice breathing, is less in the SSRI exposed kids. I'm not sure why. Might that be related? That's something we're looking at now. But the good news is it's transient. The behavioral manifestations are highly variable. Some studies say, well, okay, they're gone by 2 weeks, the classic study. And yet in our work, we see that they're really variable, and different signs have different lengths that they will occur before they disappear. So a lot of work needs to be done with that. But good news is it's transient. What about mental and motor development? Another area that has been an interesting one to follow. In this study, it's an interesting, again, a good one, because the investigator, the Canadian group, looked at sibling pairs, one of whom was exposed and one not. And it's an interesting way to look at getting a handle on some of these confounders that we've been talking about. So the mothers were evaluated in pregnancy with the CESD, and the offspring were tested for IQ levels and problem behaviors with the CBCL. So what the issue was is that the full scale IQ did not differ between the exposed and the unexposed kids, and there was no difference in the rates of problem behavior grouped that way. But when the investigator said, well, of the kids that did have problem behaviors, what were the associations? And again, it points us back to prenatal maternal depressive episodes being active and having an impact on behavior. The other important area was this concern that, and justifiably, I mean, we're so interested in finding associations for autism that justifiably SSRIs were looked at, antidepressants were looked at as a potential contributor. But those studies have largely been negative. When, again, the propensity score matching, the careful adjustments have been made, because there are potentially other factors associated with the diseases that we treat that may be associated with autism. So where are we? There's no question that if you give a drug to a pregnant woman, it affects her physiologically, it affects the fetus physiologically. That happens. There is no exposure option. And unfortunately, in a lot of cases, the treatments are not given optimally. So a lot of cases you have exposure to both disease and drug. And so what I have been really interested in is asking the question, I mean, how do we optimally treat these women from a pharmacologic standpoint? And I've been focused on pharmacokinetics. And there's some interesting things I'll show you about that, but a lot more needs to be known. We want to know which mother-fetal pairs we treat are going to do well and on what outcomes. But to do that, we have to know how to optimally treat them. And we really don't know how to do that. But my strong feeling is that if we're going to treat a woman with a medication, we deserve to treat her to remission to the extent that we can get there. So I just finished a study where I was looking at women treated with SSRIs, not by us, but in the community. And I wanted to know, were they really better? So what you see are the EPDS scores across time in a trajectory analysis. So we basically said, do all of these scores segregate into patterns? And they did. So with this blue line, the sad reality is about a third of this population of women were hovering around 8 to 12 on the EPDS, which is a high score. The other groups, doing actually fairly well. I'd like the green to be a little, but not bad at all. I'll take that. But that a third of patients with the relatively high scores were of concern to me. And again, this is a population being treated in Chicago. Why is that? Why are these women not well? And these are women who stayed on their medication because they said, I have to stay on it. I am not functional without it. So we had published some data a while ago about the changes in drug concentrations across pregnancy. And these are women, though, who called our clinic and said, my drug was working and it's not working anymore. So they're kind of a rarefied group of women who are only coming because they're having problems. And you can see for fluoxetine in its metabolite, that third trimester, there's a decrease. For sertraline in the middle, a much steeper decrease, probably a short half-life. And citalopram, the same kind of pattern. And certainly we know from multiple studies that the hepatic cytochrome system is activated in pregnancy for the majority of the enzymes that metabolize these drugs. So what we wanted to know was, if we have a population of women not selected for, gee, I'm having trouble with my mood, but we just follow them and say, well, okay, let's get monthly concentrations of sertraline in its metabolite. That's the study that we just completed. And what you're looking at here is the metabolic ratio. So sertraline gets converted to desmethylsertraline. So the faster that goes, the more desmethyl there is, and the ratio goes down. And what you see to the purple arrow is this decline, this increase in turnover of sertraline across pregnancy, and then it's bouncing back after birth. About a quarter of the women in this study did have dose increases that were given to them by their practitioners. But there you see there's a lot of variability. So whether any individual woman drops the concentration enough to become symptomatic, we're now looking at the association of symptoms with these concentration data. But I mean, the bottom line is, yes, these concentrations do drop and some women don't stay well. So now I'm going to switch over to other medications that we use in pregnancy. Again, Krista Heibruch's group has been very influential in this whole area of medications in pregnancy. And this is a study that she did to look at atypical antipsychotics. Typicals were in there as well, but we don't use those as much, so I'm not going to cover that. What she looked at was the rate of birth defects. So in no exposure, about 3.2%. with atypical antidepressant exposure, about 4.5%, within the usual 3 to 5% range that we think of in the general population of patients. But with adjustment for all of those confounders, the propensity score matching, the relationship between the drug and the overall malformations and cardiac malformations became non-significant. Except for risperidone. It's interesting. I actually wrote a commentary about this paper, and a number of us were trying to figure out what is it about risperidone in pregnancy. Now we know it affects prolactin, but the obese don't really treat hyperprolactinemia in pregnancy. So could that have some other effect? Don't know. It may be a spurious finding, but I doubt it because there were a whole number of sensitivity analyses done. So it's probably a finding, but if I had somebody stable on risperidone who was pregnant, would I change the drug? No, I would not. And again, we have some data on long-term development. And in this study, it was just published recently, all of the neurodevelopmental outcomes that you see, ADHD, any kind of disability, were looked at in terms of outcomes. Again, this is the Heinberg's group. And what was found was, again, the same story, that if you adjust for a whole series of confounders, the drug then falls out of significant association with these neurodevelopmental findings. Now, this is all very interesting, but I'll talk more about what does this tell us, right? I mean, we're interested in what does our drug do, but we're not really interested only in that, right? I mean, this is a tag that says those women who receive atypical antipsychotics do have a higher risk for kids with neurodevelopmental defects. So we have to care about that too. Maybe it's not the MAD, but what can we do to build resiliency in this population of patients? Similarly, in terms of metabolism, if we look at the concentrations across pregnancy for olanzapine, aripiprazole, and quetiapine, I think that, yeah, we see the same pattern that at least for these two drugs, because of the changes in pregnancy, the concentrations march down, and there may need to be a dose adjustment. This is not true typically for olanzapine, but again, you see the individual scatter, and I certainly have had olanzapine-treated women who needed a dose increase. So tracking is really important. What about lithium? Again, when I was trained, women were being advised by my attendings to have abortions if they were exposed to lithium because the risk of cardiac defects was thought to be so high because of the very faulty lithium registration. This is a sad story in our field, but thankfully more recent data on large populations has shown that yes, there is a higher risk for cardiac defects in lithium exposed fetuses, but it's much lower than we thought. And again, balanced against potential manic depressive illness really, I think, pales in comparison. So for unexposed and low lamotrigine exposed, lamotrigine known not to be a teratogenic drug, at least in terms of malformations, there is a higher risk. The adjusted is 1.65. So for every one baby with a cardiac defect that had no exposure to lithium, 1.65 babies with an exposure to lithium is born. Very, very low level risk. One of the intriguing things that has come out that it is not that well known in our field is that, in fact, the pathway to cardiac anomalies that is affected by lithium is a folate dependent pathway. So we now are using the prenatal vitamin plus 1 milligram of folic acid for all of our lithium exposed babies. And I put the reference here. I'm not sure why that's not more widely known in our field, but that is something that we do with the hope that we add some resilience to the milieu. Again, same story for lithium, excreted renally when the woman becomes, and this is a series of concentrations across time. So when a woman becomes pregnant, that first trimester, the lithium level drops. often have to not only increase the dose, but if she's on BID dosing, we might have to make it TID because it's metabolized so quickly. Stabilize the second trimester, and it's fairly stable. The levels may increase at the final part of pregnancy, but the point that I think is really important is early on in pregnancy is when that concentration drops, and attending to that and keeping that concentration stable is really important. What about lamotrigine? What you see on the left is all the various registries and the amount of malformations, the percentage that they see. So this is a drug that the neurologists use very commonly in pregnancy. If a woman is stable on this drug and becomes pregnant, we certainly continue it, have no problem with that in terms of malformation. The problem with this drug is that it's metabolized through glucuronidation, which is dramatically enhanced by estrogen in pregnancy. So the doses sometimes, if she starts at 200, she might end up with 200 TID by the end of pregnancy to keep that level stable. So it's critically important to see what her stable level is prepartum. And here is what happens. And it's fascinating to think about, why is it that in the red, this is 77% of the population, 70% of the population, the clearance of lamotrigine goes way up. And those are the patients that are on 200 TID at the end of pregnancy. There's a group then, 23%, the blue, who don't seem to have this level of stimulation. We do not know why. They certainly have estrogen, but we don't know why. But the other important thing is the clearance comes down very rapidly postpartum. So you really have to reduce the dose as soon as the woman delivers to avoid toxicity from lamotrigine. So it's an interesting drug. We don't start women on lamotrigine in pregnancy because typically, we know that greater than 3/4 of them are going to have, and it's hard to even get the level developed in pregnancy. So a very good drug, not teratogenic, but tough to use. Valproic acid, well known in neurology, in the neurology literature to be associated with a higher risk for malformations. And you can see the variable amounts, percentages in this table on the left. Our neurologists do use this drug in pregnancy when they have to use it to control seizures, and not all kids are affected. We worry about this drug, but it isn't all kids that are affected. It is also associated with autism. And you can see the data from the JAMA paper in terms of the higher risk for autism. I have used this drug for women with bipolar disorder. I don't like to, but I was in a situation where a woman was in the emergency room after her second motor vehicle accident from driving 100 on the Chicago highways, floridly manic. It was well known that valproic acid was the only drug that she responded to. Nobody would prescribe it. And I gave it to her in the emergency room. I mean, at some point, you have to you have to take that risk because the other risks are greater. So what about neurodevelopmental effects? I think this is really interesting with enhancing resiliency. Again, we talked about lithium and folate, but the developmental effects of anti-seizure medications are also, the development appears to be improved with periconceptional folate. So we're now recommending start your prenatal vitamin well before pregnancy, and then we add that 1 milligram of folic acid in. But even for anticonvulsants, you can see when there's folate periconceptually, the outcomes in terms of IQ are always better, particularly for valproic acid. But again, look at these IQs. I mean, a mean valproic acid IQ 95 is not bad. So again, I think we tend to really overemphasize some of the negative effects. So what do we know? The first choice psychotropic drug is the one that works for her because you've got the best chance of fulfilling that goal of controlling the illness. I always advise people to document all exposures at the time that you see the patient for an evaluation before you write the script, so that if there's a negative outcome, your exposure is not the only one that's in the medical record. Tracking symptoms across pregnancy is important. And we because again, our services are so stressed in terms of need in the community, we engage patients. So the patients will track their own mood across time and will call us when they feel like things are slipping and they may need a dose increase. So although we track them monthly, we may not see them monthly if they're stable. Concentration monitoring for those agents that we actually can monitor, I think, is really important. Reducing the dose after birth. This is interesting too. It's not so pharmacologic, pharmacokinetic. I mean, I definitely have moms who 3 months after birth are saying, I really am not comfortable decreasing my dose back to my old level because there's a lot of stress. My mother-in-law is driving me crazy. All of those things that are part of the real world. So I tend to reduce it when the mom feels comfortable. Pregnancy exposure is always much greater than through breast milk. And if a woman if a pregnant person wants to breastfeed, we certainly support that. And there are great resources. So www.postpartum.net is a support group. Postpartum International, wonderful for patients, especially if they can't get in right away. And A Mother to Baby is this organization that's DHHS supported and that I work with a lot, that has incredible resources, live chats with experts. So if you got a mom on one of our psych meds, but 3 other meds you don't know anything about, they're really good at putting that picture together for you. So you're not alone out there. What does all this mean? Well, here we have this fetus inside the mom where the physiology is trying as best it can, based on all of its evolutionary intelligence, to create a healthy, functioning organism that is going to be able to meet the world as the world is presented to it. And so you've got all of these factors happening. Well, what about in the upper corner? What about, is she obese? Is she being beaten daily? Is she using alcohol and other drugs? Or is she well situated in the Gold Coast of Chicago with all the resources possible? So all of those things are in there. And then I love this stress buffering factor. So one of my faculty, Inga Burnett-Ziegler, is doing mindfulness-based stress reduction in the context of yoga in the south side of Chicago with people in a federally qualified health clinic with a lot of success, again, wanting to build resiliency. And then maternal stress. I mean, there's so much about what does that mean? How does that get transmitted to the fetus? How can we impact that? And here we have a natural experiment happening now where we have a pandemic. And one of the concerns is, what might the neurodevelopmental effects be of the stress associated with the pandemic over the next couple of years in the offspring of these women? Not so much to the infection itself, but to the factors associated with the pandemic. And so then we have this little fetus being born. And if we can't do much with the exposures in pregnancy, can we help that woman we saw in the first slide with the baby laying on the couch and not interacting? Can we help that relationship be more skilled in terms of helping that baby regulate, which of course means helping her regulate? But I find a lot of the recovering moms do need didactics around, how do you interact with a neonate or a young infant? So focusing, over to this child piece of how do we help that pair, that family develop resiliency, which may well mitigate some of the exposures in pregnancy. I think those are incredibly important. So we are trying to, like that states, we're perturbed the system in ways towards health because the system's perturbed towards non-health in so many ways. So this is hugely complex, but I think there are incredible opportunities. We talked about folic acid, but Bob Friedman in Colorado has done some very interesting work with phosphatidylcholine supplementation and increasing the offspring's capacity to habituate. So are there more nutritional, other kinds of interventions that we can do that will improve the offspring's outcome. So with that, I'll say this final slide, mental health, fundamental to health, but certainly to maternal health, and what we do in psychiatry, psychology to support these families, I think is incredibly important. So with that, I'd be happy to take questions. Questions in the room?
Yeah. Hi, thank you so much. So one comment, because it's very interesting, is the non-replicated study in Scandinavia that showed, if I'm understanding, that there was a substantial reduction in some risk, like preterm, and also an increase in risk for other things. And I think, so I think what's important about this study probably is that it's estimating population rather than individual risk. Because even if the individual risk is minuscule, like a little bit of an increase in the relative risk at the population level, if the intervention is common, which is not yet the case, but it could still have a big effect, right? And I also wonder if part of the issue about non-replication is because in those registries, I think the threshold for, so first of all, like what they label as MDD is something that is clinically established, right? As opposed to some of the Medicaid data that may be different. And also like you were saying, the threshold for giving a medication is, as a matter of fact, different because there are more other therapies. So it's very interesting to see the difference between estimation of population versus individual risk.
Yeah, I think that's absolutely right. It's intriguing because it's the first study that's actually found diminished risk, which we think is happening. But you're right. I mean, certainly wasn't done here, and you're all the factors around the healthcare in Scandinavia, the view of people with mental illness in Scandinavia, the prioritization of pregnant people with mandated national parental leaves, the value is all very different. And you're also, right, and this is one of the things I think is really interesting as well, that when we looked at the sertraline levels in the population, the turnover, and I showed that, I go, you're right, if we look at the individuals, there's a group of individuals who have no change at all, a group of individuals who might have a slight escalation, and a rare set of individuals whose concentrations really tank. So you're absolutely right. When you look at population data, it's sort of this guide that we can tell patients, on average, we see X, but we really don't know what's going to happen to you. So right now, in terms of the medication doses across pregnancy, the best strategy we have is monitoring and adjustment. The other thing is, all of what I've presented you is pharmacokinetic stuff, right? One of the things I really wonder is, given the stress, biological and psychosocial of pregnancy, is there potentially a higher concentration requirement for wellness in pregnancy that is really a difference in the level of, say, serotonin bioeffect? We just started, so George Anderson from Yale Child Studies Center has been doing some work in adults with this, and we're just starting to now look at platelet serotonin levels and serotonin bioeffect, because that's extreme, completely unexplored area here. I believe that's the case. Hypothesis. But the other thing is, if we've got somebody that's stable on 100 milligrams of sertraline for 3 years, and some horrific event happens and they become unstable, usual strategy is to increase the dose, right? I mean, like, because of your situation and the challenge to your biology, you might need we do that because it makes sense, right? But is there a change in the way the brain physiology or body physiology needs or responds? I think all those are really open questions. And you're right, population data are a helpful guide, but they really don't change the art that we practice for the individual patient in your room. Really good point.
I'll just make a quick announcement that if you have a question online, please raise your hand and then Nicholas will unmute you.
Thank you so much for a wonderful talk. I feel you're just the pioneer in perinatal psychiatry. And I think, what you described is so clear that even 10, 15 years ago, the understanding was if a woman is pregnant, withdraw her from medication. And that's changed dramatically as a result of a lot of your work. This understanding that untreated mental illness is really consequential too. So I'm curious, big picture, where do you hope the field goes in the next 10 years and how we treat these?
One of my big hopes is that we stop doing things like excluding women who are people who are pregnant from clinical trials. So we just went through this again, where a whole number of us, including people from Mother to Baby, were upset, writing letters, calling people saying, why are pregnant individuals excluded from the COVID trials? We did a conference on this actually in 2019. And the culture change of pregnant women needing data to make decisions has not happened yet. And what happened was, this is sad, really sad story. What happened was, so a lot of pregnant people declined vaccination because they said, well, we don't know. And then what happened was, as the people who argued, well, we need to find out about it in non-pregnant people first, what are the side effects? So they found out about it and said, well, because it seems to be, I use the word safe, at low risk, pregnant women should get it. And the pregnant women still say, where's the data for pregnant women?
Yeah.
So there was a study, we participated in a placebo-controlled study after that recommendation was made by ACOG. I sit on the IRB and the potential to go through with that study passed by one vote because the IRB member said, well, we already know it's safe. Why do we need data for pregnant women? I mean, this sort of circular reasoning around. I had a federally funded study to look at probe drugs in pregnant patients. NICHD funded, my IRB declined to approve it. So we are still in this fight to get data for pregnant women. And that's sort of why I've been so active with biomedical ethics. I mean, this is public health ethics. This is a hugely disadvantaged group in terms of data for decision making. So that's one. And, we keep having government documents to change, but the culture change hasn't occurred. That's my big thing. The other thing is, I would like to see less of the siloing between adult and child psychiatry. So most perinatal psychiatrists are not child trained. And there's this, okay, we see the mom, our job is to treat the mom. And the sense of the fetus, the developing infant, the dyadic, that seems to be in our field separated into different factions. And I think that that's a disadvantage as well. The other thing I'd really like to see is moving all of our knowledge into more public health settings. So in Illinois, we have an investigator who teaches a basic form of CBT to home health, maternal home health workers, and has implemented that across the state. I mean, I really want to see us reaching people who really need it. So those would be and of course, more federal funding and private funding too.
I guess similarly on that same line, have you seen some really good innovations for moms in pediatric settings? Because I know that, one of the problems, as you are well aware of, is they get seen in OB until 6 weeks and then it's goodbye. And then they're preoccupied with their kids. And I know here we have some people who are doing great work in pediatric settings. I'm wondering if you could tell us a little bit about that, because many moms won't go in and get care for themselves, but they will for their kid.
Yeah, really, really good point. That has a sort of developmental history as well, in the sense of one of my colleagues, Linda Schroeder, who's at Rochester, was one of the first to screen pediatric populations. But unfortunately, the person who was screening, the social worker, was also responsible for deciding whether the mother should retain custody.
Okay.
So all of her EPDSs came back with 0. So,
Yeah.
And she did a lot of work then to resolve that and be one of the first to really screen pediatric populations. Fast forward, when I was in Pittsburgh, one of the pediatricians there required EPDS screening in all of the pediatric practices at University of Pittsburgh. And we were the follow-up team for her. There were all kinds of problems. Where does the information go?
Yeah, exactly.
It's not a patient. It's,
Exactly.
but we worked around that. She now is the director of the Allegheny County Department of Health and is trying to do exactly what you're saying, bringing healthcare professionals together to deal with young children to make sure they get the services that are available. So that's one piece, sort of using collaborative care that we know about in a pediatric sense. The other thing that we were talking about was a NICU. So we were just asked to collaborate with the NICU. We have a successful OBGYN collaborative care program. And so now our NICU wants us to develop a collaborative care program with them. We have perinatal psychiatry, PGY 5-6 fellows who we assign to these services as part of their training. And they're very aware of exactly what you're saying, that these parents of kids in the NICU are stressed. Some of them are behaving in ways that are really inappropriate in the milieu, and the nurses there's a high turnover rate. So I think that I did this a while when I was in Pittsburgh a while ago, and a lot of the intervention was with the nurses because they need resilience as well. And when we were working with them and they became more regulated, I guess is the word I was using, then the families settled down. But that is a real pressure cooker, the NICU, especially in these times when people are struggling to determine whether they're going to have a home, whether they're going to have food, whether. So I think, again, all of this is easy to sort of move towards getting demoralized, but I go the other way and say what we do is just so important. It really is incredibly important to the future.
Well, what a perfect note to end on. I know we've reached our time. Thank you all so much for being here.